session on stroke unit care. The first talk is by Professor Jeyaraj Pandian on managing patient in a stroke unit, the key factors. The chairpersons are Dr. Shirish Hastak and Dr. Deepak Arjundas. We are awaiting the joining of both of our chairpersons. In the meantime, I would like to invite Professor Jeyaraj Pandian to.
Yeah, thank you very much. So the next 20 minutes, I will take you through some of the important factors that changes the outcome of patients in the stroke unit. So what is stroke unit care? If you look at the evidence-based intervention that is given in the left-hand side of the table, the first row, you can see the number of evidence-based intervention in acute stroke. And if you extrapolate these interventions to a population of about 5 million inhabitants and 10,000 strokes a year, the impact in terms of extra independent survivor per year for each of these interventions is given in the table. I would like you to focus only on the last one. And this figure gives the number of patients who will have this extra independent in terms of disability, from improving from disability per year for each intervention. So if you look at that, the stroke unit service has the highest number here, so about 400. And many of these interventions happen in stroke unit. If you look at, if you combine all this, this gives a huge population benefit. And even though there is a high level of evidence for mechanical thrombectomy and the thrombolysis, hemicranectomy, etc., but only a small proportion of patients will benefit from that. On the other hand, for stroke unit, all patients can be treated in stroke unit. So that is the population impact stroke unit care has. If you look at this interstroke case control study, they looked at more than about 13,000 patients, and globally it was done in 108 hospitals and 28 countries. And if you look at the findings, in low and middle income countries, the patients had severe stroke, they had intracerebral hemorrhage, and poorer access to services, that is stroke services, and they had poor outcome. So if you have access to good services, stroke services, the outcome improves. So this is from a high quality case control study. So the evidence is so powerful that we need to really focus on the stroke care services. So what is a stroke unit? So stroke unit is defined as an area within a hospital where stroke patients are managed by a coordinated multidisciplinary team specializing in stroke management. Stroke patients who are managed in stroke unit, they have improved outcomes. So this slide is important. Why stroke units are effective? One, there is a focused care from all the stroke experts in the team, and it's a team approach. And so when you work as a team, the nurses and the doctors and the therapists, so each group focuses on certain aspects in stroke that can worsen the outcome. So you identify those factors in the stroke unit and identify it early and try to treat those factors, and you can improve outcome. For example, prevention, early prevention therapy, early detection of complication, treatment of complication, early implementation of secondary prevention strategies, early rehabilitation. And the most important thing is as a team effort, doing it together along with the families. So that makes a stroke unit effective. So what is the evidence? The one we have from 2013 Cochrane review, and the latest one also, which I'll show in the next slide. Stroke patients who receive organized inpatient care in a stroke unit, they are more likely to be alive, independent, and living at home 1 year after the stroke. It is not short-term benefit, they have a long-term benefit. And benefits are most apparent in units based in a discrete ward. So this is very, very important. It is not, in one area in a ward you keep the stroke patients and manage. No, it is a clearly distinct geographical area. So that is very, very important. And the latest evidence on Cochrane from Cochrane Library. So this is a summary from 29 trials of stroke unit with alternate service, stroke unit with general ward, about 20 trials. And so what is the evidence? People with stroke unit, people who are managed in stroke unit, again, the same, they are more likely to be alive, independent, and looking after themselves 1 year after the stroke. And irrespective of stroke subtype, whether it's ischemic stroke or hemorrhagic stroke, and the benefit is more in a dedicated stroke ward. So this is the latest Cochrane review, which clearly states that stroke unit care is the most important part of stroke management. So are stroke units effective in less wealthy areas? This is one of the meta-analysis of studies done in low and middle income countries looking at the mortality reduction in patients who are managed in stroke unit versus stroke patients who are managed in medical ward. There's a huge reduction in mortality in patients who are managed in stroke unit. These are one of our earliest studies where we compared the patients who are managed in stroke unit versus patients who are managed in medical ward, and there was a significant reduction in medical complications, reduction in mortality, reduction in terms of length of hospital stay. There was a increase in number of days because we had an inpatient rehabilitation service those days, and access to rehabilitation improved in patients who were managed in stroke unit. And recently, we had published from this Tezpur Baptist Christian Hospital, Tezpur, where a unit run by a physician, where we had this pre-stroke unit implementation and post-stroke stroke unit implementation. For almost 1 year, we collected data where the baseline data without the stroke unit, and then training was given to the nurses, doctors, and implementation of stroke protocols and stroke manual. It took about a month, and then the stroke unit was implemented and the stroke protocols. And this is a comparison. There was a reduction in complications as compared to pre-stroke unit implementation. And if you look at the quality measures, like swallowing assessment improved in post-stroke unit care, mobility, and evidence of multidisciplinary team meetings, use of secondary prevention strategies like starting antiplatelet drugs, anticoagulant drugs, antihypertensive drugs, statins, all improved in post-stroke unit care. Length of hospital stay decreased by almost 1 day. And however, the outcome was not different, both mortality as well as good or bad outcome. But the quality measures improved, reduction in complication, and length of hospital stay improved. So in the stroke unit, what are the evidence-based intervention? This is the typical the pillars of stroke care. One is blood sugar management, BP management, management of acute infarction, prevention of deep vein thrombosis, temperature management, nutrition, and all come under the stroke unit care, including thrombolysis and endovascular therapy. So FES, this is fever, sugar, and swallow assessment. This is very important. This was tested in QUASC trial. I'll just talk to you about it. They used a protocol of controlling temperature, and this was driven by the nurses in the first 24 hours to 48 hours, use of paracetamol, and if it goes beyond 100 degree Fahrenheit, you try to investigate for infections. Then hyperglycemia, you need to maintain a target of 140 to 180, and prevent hypoglycemia. You can use sliding scale or whatever, or insulin infusion. But if you have the protocol in patients with diabetes and without diabetes, and the nurses can manage this. The swallowing screen, there are multiple screening tools available, but the patient, before you feed a patient, a swallowing assessment to be done, and that will prevent aspiration and pneumonia. So this was tested in a cluster RCT in New South Wales hospitals in Australia in 19 stroke units, and it clearly showed the benefit. The patients who went through this intervention, they were 42% less likely to be dead or dependent at 90 days as compared to the controls. The NNT was 6.4. So huge benefit, and basically this is a nurse-driven protocol. Management of blood pressure, there are conditions where there are situations where BP can be low, like aortic dissection, volume depletion, myocardial ischemia, etc. You need to be careful. But hypertension can occur due to multiple factors: the stress of stroke, increased sympathetic surge, the bladder could be full, and the patient may not be able to convey to you. And pre-existing hypertension, it could be just a physiological response to hypoxia and raised ICP. So patients who receive, before receiving TPA, you need to follow a proper criteria, 185, 110. If it is above that, you need to give injection labetalol and bring down the BP. Then only you take a decision of giving TPA. And after you're giving TPA, you need to monitor the blood pressure every 15 minutes for 2 hours, and 30 minutes for 6 hours, for 6 hours, and then every hour for 16 hours. So you need to keep the blood pressure below 180, 105. And if it with repeated labetalol, it doesn't get control, you can give labetalol infusion or sodium nitroprusside infusion or GTN infusion. So in people who receive endovascular treatment, based on retrospective studies, keep blood pressure around 140 and a MAP around 70. So you need to maintain the blood pressure in these patients. What about ICH? This is from the Interact 2 trial, where within 6 hours of onset of ICH, if the systolic was more than 150, when the patient were randomized to the intensive arm, the BP was reduced within 1 hour to below 140, and it was maintained below 140 for the next 7 days. The primary outcome, there was no difference, but in the secondary outcome, there were some improvement in quality of life measures. It's not only the intensive BP reduction within 6 hours of ICH, but also you need to avoid the variability of blood pressure. Now, people with a wide variation in blood pressure in the first 7 days had a poor outcome. So you need to keep the BP after controlling in the intensive phase, but also keep below 140 in the next 7 days. So this is the guidelines, and intensive lowering is advised, particularly in the early phase. And if the BP is persistently high, more than 220, you can start intravenous infusions like nitroprusside or GTN. So medical complications are known. This is a 6-center study that we did way back in 2011, I think. But for 46% of our stroke patients had medical complications. The common one is pneumonia, UTI, bed sore, recurrent stroke, shoulder pain, psychological, etc. And complications leads to bad outcome. You can see here, poor outcome. People with poor outcome at UTI, chest infection, bed sores, depression, people with severe strokes, and they are more prone to have complications, and that also increases the length of hospital stay. So the typical patient who has a pneumonia following a stroke. So how to prevent? Semi-recumbent position, proper chest physiotherapy, mobility, suctioning, and treat if they have nausea and vomiting, prevent aspiration, do breathing exercises. How to prevent UTI? Avoid indwelling catheter. If you insert, please remove as early as possible. External catheter adult diapers, independent catheterization are useful. DVT prevention, you can use unfractionated heparin or low molecular weight heparin in high-risk patients. There is evidence about intermittent pneumatic compression from the CLOTS 3 trial. In patients with ICH, you can start heparin for DVT prevention after 2 to 3 days. What about head position? There has been a huge debate about head flat or head end up. And so this research question was tested in the head pose trial. More than 11,000 patients were randomized across, I think, more than 100 countries and 100 hospitals. And within 24 hours, the centers were randomized to go for lying flat or a 30-degree head up, and it did not make any difference in the primary outcome of modified ranking. So irrespective of the head position, if it is a very inconvenient for patient to be on flat, you can raise the head end up a little bit. Yeah. Secondary prevention, of course, antiplatelet therapy and statins and anticoagulation. You can start early. Anticoagulation based on the type of cardioembolic stroke, you can delay or start early, and you need to start the management of diabetes, hypertension, extra and other risk factors in the stroke unit. Rehabilitation is important. The multidisciplinary team, the patient should be assessed by any of these therapists, and they need to have an early goal setting, involvement of the carers, very important in the early stage, and mobility after 24 hours is recommended when the patients are stable. This is a trial called EVERT, which studied the early mobility, that is within 24 hours. Early mobility based on this trial is harmful. You should not mobilize these patients, but after 24 hours, if they are medically stable, you can start the mobilization. However, all the other passive exercises and other procedures in rehabilitation can be followed. And there is a trial called AVERT Dose, which is ongoing. India is also participating, where the time duration and dose of for the exercises are being tested in this AVERT Dose after 24 hours. Family carer involvement, it's from the ATTEND trial, which was carried out between 2014 and 2016. 1,250 patients from 14 centers in our country were randomized to an intervention arm where the physiotherapist taught the caregivers when they were in the hospital with 3 sessions of 1 hour each, and the physios had a home visit for the first month, and the relatives were trained to deliver the rehabilitation exercises, and the outcome was assessed at 3 months and 6 months. The task shifting was neutral, but however, from the process evaluation that we did later during this trial, this was an acceptable model, and people, stroke patients, relatives, and stroke patients, they wanted this type of model. We have designed a ATTEND 2 trial. We are just awaiting funding for that. Early supported discharge. This is another concept where the multidisciplinary team sit together and plan the discharge from each of their areas. What is the plans? And from the physician side, what is the plan in terms of prevention of stroke? And from the nurses side, in terms of prevention of bed sore, mobility, falls, and from the therapist side, what are the exercises, home programs. So when you have this multidisciplinary team plan, and that reduces the hospital stay and improves outcome. This is from the Cochrane library. So models of, finally, I'll touch upon the models of stroke care. India is diverse, and each developing country is diverse in terms of health infrastructure and the facilities. So one of the earliest model Dr. Padma developed through Himachal government is the hub and spoke model. There are 2 hubs where neurologists were there, and the spokes were district government hospitals where they were trained using stroke protocol, SOPs, and they were able to deliver thrombolysis and initiation of stroke unit care. And we initiated in Ludhiana area through stroke surveillance and stroke registry in about 2.5 lakh population. By training Ashas were able to identify stroke patients in the villages and refer these patients to the stroke units, in the civil hospital and to CMC. This is the Punjabi version of FAST, which was put up in the villages and the gurdwaras. And with the Punjab government, Dr. Padma, Dheeraj and me, in 2016, we started this program with the training of all the healthcare workers from Punjab in the government hospitals. And Dr. Dheeraj and me, we mentored about 3 or 4 district hospitals and 1 medical college hospital, and we started the stroke unit and the program. This is based on physicians. IVTPA is available free of cost, and it is integrated with 108 ambulance. However, because of pandemic, all has been disrupted. We are trying to initiate, and there are other states like Kerala, UP, and few other states where this is being implemented, including Tamil Nadu. And if you look at the various models, this is one review that we published recently last year, which summarizes all the models available in different LMICs. One is the typical specialist-led care, the physician-led care, and in the government hospital and in private, task sharing model, the ASHA model that we had developed, and the multidisciplinary team. So there are models available, and people can adapt, look at it, and adapt whatever is feasible in their own country. So globally, there is a program called Organized Stroke Care across all income levels in Africa and in some centers in India. We have completed this project. The paper, there will be a special issue from International Journal of Stroke where all the countries' data will be published. So 2 centers from India were selected. So in conclusion, stroke unit care is essential for acute management of stroke. Most of the things happen in stroke unit: thrombolysis, secondary prevention, rehabilitation are related to stroke unit, earlier identification of factors that lead to secondary neuronal injury, and identifying these key factors and starting the intervention improves stroke outcome. And many of these protocols can be led by the nurses. And there are several stroke unit models available in LMICs. And for more reading, there is from the World Stroke Organization, World Stroke Academy, there is a teaching module available. And if you're interested, you can access. It's free to use. So I thank my entire team locally here for all the support, particularly for the research that we have been doing from our center. Thank you very much.
Thank you so much, Professor Jeyaraj. Unfortunately, we didn't have the chairpersons. Has Dr. Hastak joined in yet?
Yeah, I'm here.
You? Oh, yeah. Welcome.
Yeah. Sorry about that.
I'll hand over it to you. Just one question for Dr. Jeyaraj in the chat box. So I don't know whether Shirish you want to take that up. I mean, ask Jeyaraj. There's one question which says whether we use low molecular heparin as prophylaxis for DVT in acute ICH cases.
Yeah, it is recommended after 48 hours. Yeah.
After 48 hours. After 48 hours. And would that be irrespective of the size of the ICH? Would volume of the ICH count or no?
Size, no, it is more. I'm not aware about the evidence, but the guidelines, they say it is 48 hours, after 48 hours. And each patient, you need to look at it. And if you feel it's very big, and wait for some time. Yeah.
This is a really tightrope walk in any case. I need to individualize. Thank you so much.